So first of all, I would want people also to tell me, do they want these classes or not? I want I feel that the number of people who are attending these classes is getting lesser and lesser. So if it is too much of a burden, then we can discontinue these classes for some period of time if you want it that way. If people are not keen on attending, then it's fine with us, because this is some time spent by the faculty as well. So I want people to speak. Yeah, Shashank, what's your view on this? Can I have your video? Everybody to have their videos on. Ashir, everybody with video on. Shashank, what's your view on? Do you want these classes or you don't want these classes? Shashank is, I don't think is. So that's my fear, that many of these people probably switch on their connections but are not there. I don't know if Shashank is even hearing, not responding.
So he's sending a message on the chat box that he's trying to change his settings.
Yeah, that's the problem, I guess. So Sunil, can I have your views? Sunil. Sunil, not there. Anish. See, if you're not wanting to even speak, then there is no point in having these classes. I think we can stop having these classes. Yeah, Shashank, I can see you now.
Yes, sir.
Yeah, what's your view on this? Do you want these classes? So what's the view of people as such? See, I feel that the numbers have gone down. One is that obviously the new batch is not there, but new batches were never joining in any case. New batches always used to be probably working. I can understand that some of you are probably working still on the wards and obviously may not be able to join. So the numbers would go down. But I feel that probably, is there anything else that I feel that we should know? Then we could either modify or whatever, because it's very important that because the faculty is spending some time on it and it should be useful. If you feel that it's not useful, then there's no point in wasting time on it. If you feel you're getting enough of education in your own units, then it's fine. I don't think we need an additional kind of a thing. So I want to hear this. We started this some time back with the idea. People have changed. Maybe the newer people do not want this, or they want it in any different way. So unless you tell us as to what is you want, we could either cancel it, we could either continue with some modifications. Or so it's very important to get the feedback, and I think you need to be open about it. There's nothing to feel bad about it. Don't consider it will be an insult to the faculty itself, because ultimately it is being done. It was started with the feeling that this is something which was needed. Maybe it's not needed. We started in 2016, 2021. Maybe it is not needed. Maybe you feel that probably it's okay. So what is it? Do people want? Shashank, I want your views.
Yeah.
You may not have talked to the people, but give me your view on this. You are what? You are a
Yes, sir. Yes, sir. I think
you
we
are a
should.
third. You are a third year.
Yes, sir. I'm in third year right now, sir.
Yeah.
And I want these classes to continue, sir. There is no doubt about that. These are very helpful, sir. And definitely we don't learn so much from this faculty at our center. Um, we all know that's how DNB course runs at many of the centers. So these classes are very helpful to us. I can understand, sir, there is less participation, I think from last 1 month maybe. It could be due to, sir, thesis submission stress in last this month, and obviously delayed in the batch of recent batch also.
Yeah, there is, I
So
can understand
uh,
that.
there
And so
is,
some of you are
and the
some,
workload has also comparatively increased compared to the COVID times. There's like backlog which has transplant patients in admissions. Everything has like obviously has increased in last 2 months. So these could be the factors related to the less attendance. Although these don't justify missing the classes, but this could be the like factors.
any other view in addition. Yeah, I can possibly understand that part of it may be related to this, but anything else? Anyone? Be free. Don't hesitate to speak. So please feel free. Anyone else? Any other view or anything else that you would want us to do? I sincerely, there is somebody is saying, what is he saying? I sincerely feel these classes should continue. I have finished and passed my DM examination, and I know very well this, it will benefit many. This is Anish. Okay. Okay, then let's at the moment for the day, let's continue it like this. So what I have done today is I prepared a patient who is a real patient actually, and we'll go over it and let's see how the clinical details unfold and how we would think about this patient as well as how we would manage this patient. So this is a 26 years female. I just want everybody to keep their videos on. I don't want, you can switch off your or mute yourself, but keep your videos on. I would want people to be engaged with me. So I want to see everybody. So this is a 26 years female. There isn't any past history, and she got married about 1.5 years back. And the history starts when she was 6 months pregnant, and she was found to have hypertension at 6th month. She also was found to have proteinuria on routine urine analysis, and a serum creatinine was 1.3 milligrams per deciliter. She doesn't remember her serum creatinine ever before, and she felt that some tests were done at the start of her pregnancy when she was first found to have been pregnant, and but she doesn't remember that she knows about her serum creatinine. This time at 6th month of pregnancy, when she was found to be hypertensive, her serum creatinine was 1.3. Urine analysis was showing proteinuria. She was given nifedipine for control of blood pressure and delivered at 34 weeks by a C-section. She delivered a male baby, 1.8 kilograms of weight. Serum creatinine done on 4th day after the delivery at the time of discharge was 1.8 milligrams per deciliter. The liver function tests are normal. Her hemoglobin is 9.8 grams. And 4 weeks after the delivery, for her persistent high blood pressure and a serum creatinine of 1.9, she was asked to see a nephrologist. And that's how she came to see me. She is basically quite asymptomatic, doesn't have any other symptoms, except that she had a fall in the bathroom and hurt her right knee, and which is swollen. So there is some swelling and on her right knee. So this is all that is there in the history. There isn't any history which is suggestive of any urinary tract infections like dysuria, fever, frequency. And she doesn't say in the past or in early childhood. She also doesn't remember her mother having told her that she has had any febrile illnesses during her early childhood. At least she is not aware of it. And there isn't any history of pedal edema, and she doesn't remember that she ever knows about her serum creatinine ever before. No history of fever, joint pains. That's all in the history. So there is this young lady with who at 6 months of pregnancy is found to be hypertensive, has some proteinuria and a creatinine of 1.3 at the time of 6 months of a pregnancy, and then after delivery about 1.8, 1.9 milligrams per deciliter. So the question is that what's going on in this patient is obviously, the questions would be that did she have kidney dysfunction before, or did it happen during the pregnancy itself? And if it happened during pregnancy, then what are the conditions which can cause this kind of a, or was some pregnancy event which caused further deterioration over an underlying kidney disease or something like that? So we have to look at it from a perspective that is there an underlying kidney disease which was unmasked during pregnancy, because pregnancy is a stressful situation for the kidney, and therefore many diseases which remain asymptomatic or undiagnosed might get manifested first time in the pregnancy. So one will always have to keep into consideration, is there an underlying kidney disease which got unmasked about it? And if there was a kidney disease, what kind of a kidney disease was it? And now hypertension in pregnancy at about 6 months, second, borderline third trimester, is it preeclampsia with some proteinuria and hypertension on top of it? Either on an underlying kidney, or would you think that this is a first pregnancy, or is it all preeclampsia? And the creatinine is 1.3 milligrams per deciliter in 6 months, and the creatinine at 4 days after delivery is about 1.9. So Vivek, can you tell me what happened to this creatinine? 1.3, then 1.9. Is this deterioration in kidney function, or what has happened? Why would you think that the creatinine has gone up?
So no, physiologically in pregnancy is a stage of hyperfiltration. So during pregnancy, the normal serum creatinine falls to around 0.6 to 0.7 milligrams per deciliter. So a 1.3 milligrams of per deciliter of serum creatinine during pregnancy, which would not be that high in normal person, is actually quite high in a pregnant woman. Sir, then the thing, as you said, sir, was it a AKI or was it an acute on CKD is what is to be determined. So because you said, sir, that she had a new onset hypertension post 20th week of gestation, so it was probably a gestational hypertension. So a gestational hypertension and a renal dysfunction which did not improve, did not settle down after even after delivery of the baby. So perhaps it was an underlying kidney disease in the patient, which basically that is why, sir, the serum creatinine was 1.9 after delivery.
Yeah,
so I think the patient does
yes.
have an underlying kidney disease.
Yeah, I think that's right. That this patient had at the time during the pregnancy, the creatinine was 1.3. There is 30 to 50% increase in glomerular filtration rate during pregnancy, and that would cause a decline in the serum creatinine. And therefore, when delivery happens, and usually although these changes might take sometimes 4 to 12 weeks to return, but most of the time they would return probably in about a month's time back to the pre-pregnancy state. And therefore the serum creatinine, true serum creatinine, in fact, is 1.8, 1.9 and not 1.4, which is what you said very rightly. So let's go. So these are the things which should probably get into the mind whenever you are hearing a history, and your thought process should start clicking that, is this an underlying kidney disease? Is this something acute? Is it acute on chronic kidney disease? And what could be the causes for such kind of a chronic kidney disease? So let's see if there is a physical examination helps us in any way. She is otherwise looking healthy and has a weight of about, well, somewhat malnourished to some extent, weight of about 44 kilograms, pulse of about 74 per minute, blood pressure is 140/90. All pulses are palpable, height of 5 feet 1 inch, BMI of 19 kilograms per meter square. She's on nifedipine 10 milligram twice daily, and the blood pressure I said was 140/90, and also taking ergomin 0.1 milligram twice daily. She has minimal pedal edema, pallor, no lymph nodes, and systemic examination otherwise is unremarkable. And a urine routine examination, which is what you always get, or you do it, shows an albumin of 2+ and a specific gravity 10-20, WBCs of 4 to 6, and RBC 1 to 2. So is there anything else you would want in the physical examination, Vivek, in this young lady? Do you think something that you would specifically?
So I would look for, I would want to know about the hypertensive retinopathy.
So you would want to know the fundus. So I have
Yes,
kept
sir.
fundus as an inquisitive kind of thing. Though somebody should have looked into the fundus, or we should have an ophthalmological examination of this fundus to look for hypertensive retinopathy. Anything else in the physical examination, specifically maybe more? I will look for renal bruit as a cause of hypertension in a young lady. So would specifically look for, I will listen to the renal bruit itself. On physical examination, you will look at the renal angle. So where would you Vivek listen for renal bruit? Which place?
Sir,
anatomically?
So 1 centimeter above and lateral to the umbilicus and on the renal angles.
And on the renal angles. Yes, that's perfectly right. And so you should do this examination complete, not be perfunctory about this exam. So renal bruit. And I would also look for if there is a left ventricular hypertrophy. So on physical examination, these are the points where I would be more specifically looking for left ventricular hypertrophy, which will tell me that the hypertension has been either uncontrolled for some period of time, and she didn't know probably about the hypertension. Hypertension may have been there as a manifestation of asymptomatic manifestation of chronic kidney disease, because that's what I am looking at in this patient. So on physical examination, these are the things which I would be definitely focused. So as I said, the differential diagnosis which has been going on, physical examination, there's no renal bruit. Fundus has shown grade 1 hypertensive changes, basically not much, and cardiac examination doesn't show left ventricular hypertrophy. So basically it tells me that hypertension, at least if at all is being present, has not been present for long periods of time, and may not have, because left ventricular hypertrophy is not there. The grade 1 changes may be changes which probably occur when the blood pressure goes higher than what it has been, which may have happened during pregnancy itself. And the spasms that you see in the retinal vessels may be related to the acute increase in the high blood pressure that you may be seeing. So that's probably the way I would look at this patient. And so the differential diagnosis, as I said, I would feel that she probably, as Vivek said, probably has an underlying chronic kidney disease. And I feel probably it got unmasked during pregnancy, second trimester, third trimester, borderline. She may have a superimposed preeclampsia. At the moment, I don't think so. I would, and whenever you are looking at diagnosis on history and physical examination, you must keep a broad categorization of the differential diagnosis. So don't make just one diagnosis. Try to include other things also included. So I would not at this point of time totally rule out a preeclampsia on top of an underlying chronic kidney disease, which may have aggravated her hypertension. And it could be that the hypertension may be just an aggravation of the chronic kidney disease itself without any. So it gets sometimes difficult. Now, Vivek, tell me, if one were to look at whether this is superimposed preeclampsia on a chronic kidney disease, or it is chronic kidney disease on its own, is there a clinical differentiator or something that might help you looking at whether this is preeclampsia superimposed on chronic kidney disease, and or it is chronic kidney disease by itself? Hypertension can be part and parcel of chronic kidney disease, which is aggravated to some extent by regular. And is it really important even to know this?
Sir, a superimposition of a preeclampsia on a background disease, sir, could be indicated by new onset worsening of a well-controlled blood pressure, that is sudden increase in requirement of antihypertensive drugs, or sudden increase in proteinuria. So these are the two markers that can help us gauge a new onset preeclampsia superimposed over a chronic kidney disease. And sir, the diagnosis of this is very important, because preeclampsia has its own prognostic implications in pregnancy as well as postpartum. So because it again increases the risk of premature deliveries, it increases the risk of stillbirths, also increases the risk of progression of CKD postpartum. And so it basically has a bearing on both the maternal and the child's health.
Yeah, I would agree. But then chronic kidney disease by itself and hypertension as a part and parcel of chronic kidney disease will also probably do similar kind of things. Basically, will predispose a child to prematurity, as well as to low birth weights and poor growth, as well as maternal kind of effects on kidney function, as well as on the outcome of pregnancy itself also. So all of these could be probably preeclampsia itself. I agree. The things which might help you would be a uric acid. Normal pregnancy, uric acid is on the lower side. Chronic kidney disease, if you have a background investigations available and suddenly there is a rise in the uric acid, then it usually might reflect preeclampsia. And then if the blood pressure is not very high and it's reasonably controlled, looking at the fundus during this state might help you, because you find severe vasospasm, which would be characteristic of preeclampsia rather than just a manifestation of blood pressure. Well controlled, reasonable blood pressure probably may not show you much changes in the eyes itself. So a high uric acid out of proportion to the degree of kidney function would always be a feature of preeclampsia. Might help you to distinguish it. But yes, from management point of view, theoretically, it might be of interest to the examiners to know whether you know the differentiations here and there. But from practical point of view, probably control of blood pressure is the most important thing that you will do as far as this patient is concerned. And I think the concern should be predominantly of control of blood pressure in these kind of situations, and trying to avoid complications of chronic kidney disease in this group. So that's probably the most important thing that needs to be looked at. Now, the question which also arises is, what could be the cause of chronic kidney disease? Now that we are thinking that this is a chronic kidney disease, an underlying chronic kidney disease, can we make any guesses as to what is the kind of differential diagnosis that we can think of? She denied any past history of either edema or even manifest blood pressure or anything, no history of hematuria, oliguria at any point of time. So no past history of an acute nephritic syndrome, nephrotic syndrome, or at least a glomerular kind of a disease that one can think of. So if at all, it at least clinically manifest glomerular disease is not evident from the history nor on the physical examination at this point of time. Could she have an underlying, I can't rule out a underlying asymptomatic glomerular disease, which may have been the cause of chronic kidney disease. Difficult to rule out totally. I can't pinpoint, is there an underlying interstitial disease, which usually is asymptomatic most of the time, by and large, much more commoner than asymptomatic glomerular disease causing this disease. So I'll have to keep in the possibility of an interstitial nephritis as the cause of chronic kidney disease, and I can't rule out at this point of time. As I said, I should keep broader outlines of my differential. I can't rule out totally an underlying glomerular disease. Hypertension itself as a cause of, she's 26 years old, if at all, primary hypertension would be unusual, but not that it cannot happen, it can happen. But at least that would not be, she hasn't manifested previously as hypertension, although during pregnancy, hypertension for the first time might get manifested by preeclampsia as such. But hypertension causing chronic kidney disease if it's a parenchymal kind of a disease itself as a cause, primary hypertension causing kidney disease because of hypertension would be odd. She hasn't had episodes of uncontrolled hypertension or any symptoms related to uncontrolled. To believe that asymptomatic hypertension will cause chronic kidney disease as a primary hypertension causing chronic kidney disease of this sort would be very, very unusual. So I don't think that she has a primary hypertension. Now, could she have renovascular hypertension? I will have to look at that also as a cause. So Vivek, do you think anything in the history which would suggest she hasn't? Usually you think of renovascular hypertension if there is usually a sudden severe hypertension presenting in a young person. She hasn't presented with that kind of a thing. First time being seen as in a pregnant patient would be odd. Kidney dysfunction during pregnancy itself, renovascular hypertension, somewhat odd. Again, it remains lower on my card, but it should be brought into the discussion point that you should keep in mind, but looks very, very unlikely. So the most likely diagnosis looks to be a parenchymal disease to me, because there is renal dysfunction in addition. And I feel that the renal parenchymal disease probably that I could think of is chronic interstitial disease. Can't rule out an underlying glomerular disease. Primary hypertension, very, very unlikely. And secondary hypertension related to renovascular disease, again, very, very unlikely. So would that be okay with all of you, or you feel that there are other possibilities which should be kept in mind? Anyone can suggest if there is anything, raise your hand, or just.
Sir, excuse me, sir.
Yes.
Sir, there is proteinuria. Protein is 2+, so IgA nephropathy can be a possibility.
Which is glomerular disease. So you could,
yes,
if you were to look at glomerular disease, would be an IgA nephropathy. But yes. 2+ proteinuria, it's good you brought that point. Let me get to this urine analysis, and then you have 2+ albuminuria. In addition, I gave you certain other things. If you were to put it into a quantifiable proteinuria, 2+ proteinuria would mean what? What does it tell you in terms of quantification? Say if you were to do a 24 hours urine protein and just make a guess as to what would be the likely 24 hours urine protein on a 2+ urine protein, so what it would be? And what are the things which will make a change in that assumption of yours? So what is something that you would want to know?
So the pH, sir, pH of the urine.
pH, I don't have it here, but more than the pH, how would pH affect the quantification of protein?
No, sir, not quantity.
It is a specific gravity, sir. It is a specific
gravity. Yes, specific gravity. And I gave you specific gravity. That was 1020.
1020, yeah.
1020. So 1020 specific gravity tells you what? Yes. क्या नाम था इनका? This
Sir, Mohit.
Mohit. Yes, Mohit. You tell me. 1020 specific gravity tells you what?
Sir, concentrated.
So it's a reasonably concentrated
Reasonable.
urine. It's
Yes.
not a dilute urine. So in a concentrated urine, if you have 2+ proteinuria, what would be your estimate of 24 hours urine protein? Would it be nephrotic range proteinuria, or you think it would be? Why do you do urine protein creatinine ratio? You do urine protein creatinine ratio only for this purpose.
Yes.
That you want to quantify the amount of protein. The 2+ albumin in a urine analysis doesn't give you this because it's a concentration. Ultimately, it's the amount of water. If you dilute your urine, you can make 4+ protein into 1+ or 0 even, depending on how much of water you drink. You can fool if you want to prove your urine to be negative when you are going for, say, admission test to a university or to a job, and you may have 1 or 2+ protein, but you want to say that your urine is negative or protein, drink large amounts of water just before going for urination and giving that urine for testing, so that your urine gets diluted and it shows either trace protein or 0 protein. And if you want to show that your protein has large amount, don't drink water. Your urine in the morning get concentrated, and that's how it is. So that's why specific gravity helps you to distinguish. Is it a urine sample which is dilute? 1 or 2+ protein in a dilute urine may be equivalent to 4+ protein in a
normal.
In a normal. So that's the reason. So albumin of 2+, yeah, it could be still consistent with that. You may have 1.5 grams of proteinuria, probably not a nephrotic range proteinuria. But I agree, IgA nephropathy, many times proteinuria may not be nephrotic range proteinuria at presentation. And I think that's why I can't rule out an underlying glomerular disease. That's why I have kept underlying glomerular disease, although clinically there isn't anything else to suggest it. But a urine routine examination of 2+ is consistent with either an interstitial nephritis or even a glomerular disease like an IgA nephropathy. It could be 1 to 2 RBCs, few WBCs, could be still consistent with even a membranoproliferative glomerulonephritis. Creatinine of 1.9 at presentation. I don't know what it was before pregnancy. So it's quite possible that there may be an IgA nephropathy. There could be other glomerular diseases if one were to look at glomerular diseases. So that's why the chronic kidney disease is either an interstitial nephritis or a chronic glomerulonephritis. And IgA nephropathy would be one of the differential diagnoses if one were to look at, or a membranoproliferative or mesenteroproliferative glomerulonephritis also. Membrano more because there is renal dysfunction also at presentation. Even focal segmental glomerulosclerosis could be there. Some 2+, 3+ proteinuria. I don't know what it turns out to be in a quantified urine. And then few RBCs here and there, WBCs would be still consistent with a diagnosis of even focal segmental glomerulonephritis, if one were to look at differential diagnosis of a glomerular disease in this patient. Okay. Anyone else with anything else? So how do we proceed further? Mohit, now you would want, we were talking about sort of going ahead and doing, so we would do a quantification of urine, and the UPCR and the 24 hours urine protein is about 2 grams per day. So it doesn't help us in any way. It tells us that it is still possible that this may be an IgA nephropathy, a glomerular disease, consistent. It doesn't rule out an IgA nephropathy. But however, 2 grams of proteinuria in a 26-year-old man, and I feel that it may be still consistent with an interstitial nephritis. Isn't it? Is it possible or no? Chronic interstitial nephritis? If it is consistent with chronic interstitial nephritis, Mohit, what kind of possibility would you keep? What kind of interstitial nephritis?
So the urine would have been dilute
If it is
chronic interstitial nephritis, then diluted, like specific gravity.
why?
Would have.
Creatinine of 1.9, I think. Kidney continues to concentrate and dilute urine till very advanced stages of chronic kidney disease, whatever the cause, interstitial or chronic. The pathophysiology of chronic kidney disease continues to remain similar, actually, whatever the cause. Whether it is interstitial disease, there may be relative greater effects on concentration and dilution in interstitial disease in comparison to glomerular disease, but overall, the pathophysiology of chronic kidney disease, irrespective of whatever the cause of chronic kidney disease, predominantly is able to, kidney continues to concentrate and dilute till very advanced stages of chronic kidney disease, like stage 4 or 5. She has probably an estimated glomerular filtration rate of about 40 ml or so, which is a moderate kind of chronic kidney disease, if at all. So then that would be probably okay. So I don't think you would be. But what kind of, any other person can tell me what kind of interstitial disease would be consistent with a proteinuria of about 2 grams in a young lady who is 26 years of age and
Psychoureteric reflux.
Yeah, vesico-ureteric reflux causing scarring in the kidney and chronic pyelonephritis, and secondary focal segmental glomerulosclerosis. Wouldn't that be possible? That is how proteinuria occurs in patients with chronic pyelonephritis related to reflux nephropathy. And they can have even nephrotic range proteinuria later in life. And that happens because of the secondary FSGS. And that secondary FSGS occurs because of what?
Sir, hyperfiltration in an attempt to compensate for the loss of nephrons.
Yes, one could be a hemodynamic effect, compensation related to hyperfiltration and increase in the glomerular size of the remaining nephrons and all that. So hyperfiltration which occurs in the remaining nephrons and all that. Could it be an immune mediated also? Interstitial damage leading to, it's been postulated and that has been documented that you have actually one kidney which has scar and the other kidney is reasonably okay. Even in these conditions, when the hemodynamic effect should not be very high, the other kidney is reasonably okay. It doesn't show that much of scars, but they continue to have progressive proteinuria in reflux nephropathy. Reflux nephropathy affecting one kidney more than the other kidney. The other kidney is not showing too many scars at all. On ultrasound, DMS scan looks reasonably okay. But some of these patients also have progressive proteinuria and renal dysfunction. And you do a biopsy on the other side, the kidney shows focal glomerulosclerosis. So I'm talking of a relatively better looking kidney shows also focal glomerulosclerosis. So some people feel that that's an immune mediated focal segmental glomerulosclerosis related to probably a tubular antigen because of the interstitial damage in one of the kidneys getting antigenic, becoming antigenic, and the body then launching an antibody against it, and immune-mediated disease occurring in the other kidney also. So experimentally, there is some documentation and proof for that kind of thing. But by and large, yes, I agree that in reflux nephropathy, by and large, it's related to, usually it's a bilateral thing, and usually one kidney may be affected more than the other. And most of these people will progress to a progressive chronic kidney disease, leading ultimately to an end-stage kidney disease at some point of time. And focal segmental glomerulosclerosis, usually an adaptive mechanism related to hyperfiltration, but an immune-mediated nephritis has also been implicated as a cause for progressive glomerulosclerosis. And that's why you can see proteinuria in many of these conditions later in life, okay? So we quantified it's about 2 grams. What else? We would obviously look for a CBC and look for hemoglobin is 9.6 grams, total leukocyte count of 6,400, platelets are normal. An MCV of 27%, MCHC of 30%, and MCH 20%. Peripheral smear shows anisocytosis and hypochromic red cells. So what does it show, Mohit? A hemoglobin of 9.6 and all the other parameters that I talked about, what does it tell you? That she's got.
It is promoting CKD diagnosis.
No, what does this hemogram tell you?
Sir, microcytic, it is
microcytic hyperchromic anemia tells you what?
Sir, iron deficiency.
Iron deficiency. So iron deficiency anemia. So I think the important point which I want to bring out is that although you can do iron studies to find out whether there is an iron deficient state or not, but looking at the hemogram itself should be an effort so that you can get the clues about microcytic hyperchromic iron deficient anemia from this hemogram itself. The MCH and MCHC, these will be lower parameters. So looking at the peripheral smear and the MCHC and the hemogram parameters itself. So make a habit of looking at these parameters. Sometimes you look at hemoglobin and don't look at these parameters at all, and therefore may not be able to interpret it. So therefore make it always a habit that when you look at the hemogram, you say, okay, is it? Even without knowing the iron, you will know that this is an iron. And this helps you from the point of view that you have a poor patient who iron studies are somewhat more expensive than doing a CBC. A good CBC in a good clinician's hand will tell him that this is iron deficient anemia and will make him say that, okay, I need to treat this iron deficient anemia without getting the iron studies done. So you can make your choices based on that kind of thing, availability of funds of a particular person, and you can choose it to be. So it's important to start looking into them. If you don't make a habit of looking into them, then you will not get hang of what it is. You'll always order iron studies in a patient. Wherever people can afford it, yes, you should have additional information about it, and then you can see how things change also. So that's something that's important here. The creatinine clearance was also done, and that's 42 ml per 1.73 meter square. The estimated GFR at a creatinine of 1.8 is about 37 ml. Serum proteins are 6.2, albumin is 3.6, calcium of 8.4, phosphorus of 2.2, sodium 136, potassium 5.2, PTH is 60 picograms, and vitamin 3.2 nanograms. So that's about the biochemical investigations that you have. Serum creatinine, I told you, was 1.9, and the eGFR was 37 ml per minute. So in addition, so biochemistry tells you that this is a patient who's got a chronic kidney disease. There is no hypoalbuminemia at the moment, and 3.6 grams of per deciliter. So that probably tells me that not being in a nephrotic state for any period. So the proteinuria itself is also non-nephrotic, the proteinuria of about 2 grams or so. So we need some more information. We know that this is chronic kidney disease, probably some renal dysfunction there. GFR is low, but we don't have. We have other serological markers, the complement, C4, ANA, hepatitis B, hepatitis C, HIV. In all patients with chronic kidney disease, especially with some proteinuria, you should look at hepatitis B, C, and HIV. These are negative. C3, C4 are normal, and ANA is negative. So doesn't look like, at least the glomerular diseases with complement kind of alterations would have favored probably a diagnosis of a glomerular disease. But I can't rule out, just because these are absent don't mean that I can rule out, like you said, Mohit, IgA nephropathy. I don't think we can rule out at this point of time IgA nephropathy from that difference. So it still remains at the back of my mind. So I'll get an ultrasound done, which has not been done so far. So the ultrasound shows right kidney to be 6.8 centimeters with increased echogenicity, and left kidney is 9.4 centimeters, normal looking on ultrasonography. A Doppler of renal artery was also done, since renal arterial, we were looking at renal artery stenosis as a diagnosis, and now one left kidney is smaller than the right kidney. Right kidney is smaller than the left kidney, so it appears that there may be a renovascular hypertension. So renal artery suggestive of that there is narrowing of the right renal artery, and left renal arterial flows are normal. So Mohit, what do you think? You think this is renal artery stenosis, or this is small right kidney, the left one is normal looking, or do you think that this is right pyelonephritic kidney? So now how do you, what's going on in your mind? If you were to see this patient, so what's going on in your mind? So this is a kidney which is right kidney small, and the Doppler suggests that the right renal arterial flows are low. So there is some flow problem in the right renal artery. So is this a small kidney, or you think it's renal artery stenosis?
Renal artery stenosis can be possible.
Can be possible, yes.
Yes.
But
angiography.
But if you have a kidney, now let me give you a scenario. If you have a kidney, because we consider that there may be a pyelonephritis which occurred, because that was one of our concerns, that this is a reflux nephropathy. Now, if you have a reflux nephropathy causing a scarred kidney on the right side, what happens to the renal blood flow? So and when does scarring occur usually in a reflux nephropathy? Usually what age usually reflux causes scarring in the kidney? Anyone else?
Sir, around second decade of life usually, sir.
No, why do you have to wait for reflux? Is usually present in early childhood, usually. So it usually recovers. In fact, 40 to 50% of reflux usually recovers by itself, isn't it?
Yes, sir.
Usually by 4, 5, 6 years. Many children during early childhood may have reflux, but many of them will recover by the time they are 6, 7 years of age. And usually when you look at reflux nephropathy, prophylaxis is usually given up to 5 to 10 years, not more than 5 to 10 years. By and large, 10 years, by 10 years of age, you would think that most of the people would stop giving them prophylaxis, because majority of them, very small percentage of them, may have persistent reflux in them. So, and most of these reflux which cause scarring in the kidney would happen very early in childhood. They get infected. Many times they don't know. They get febrile illnesses. They're not diagnosed at that point of time many times as having urinary tract infections, because unless the parents are very, very knowledgeable and take them to pediatricians, and pediatricians look at them, maybe now, but many of these children remain undiagnosed with febrile. They get an antibiotic, they get better. Many of the symptoms subside, they get recurrent. Another 1 month later, another episode of febrile illness. And that's how you diagnose these patients with early childhood that they probably may have had. And someone, an intelligent pediatrician might then look at that, is the urinary tract, or an ultrasound these days allows these children to be diagnosed with a reflux. So usually this would happen within the first decade itself, not in the second decade, not in the second. In fact, you stop prophylaxis of urinary tract infections usually beyond 5 to 10 years in these patients. So this scarring occurs very early in their treatment. So usually within 4 or 5 years of their life, they will have scars in the kidney. They remain asymptomatic. Many of these patients may never give you this history. They themselves will not know it unless their mothers have told them that you were a bad child in your early childhood. You gave me a lot of trouble. Every month I had to take you to a physician because you would get these fevers which nobody knew what was the cause of this. And most of the mothers may not tell their children because they don't want to tell them that they were troublesome during the childhood. So you will many times not know them. And that's what happens when you see patients in the clinic. They will deny you any history of urinary tract infections, because in later life, the urinary tract infections don't occur frequently. In some patients, they will continue to happen, but majority of these patients, you will find that they will not occur. And you do a DMSA scan and you will find scars in both the kidneys and all. And later on, they manifest usually as hypertension in young adult life, 20s and 25, 30s, third decade or so, they will present as hypertension, and some will, ladies especially, will present during pregnancy. They get married, they don't know, and within 1 or 2 months of their pregnancy, they start getting urinary tract infection or kidney dysfunction and hypertension. And that's how they will be picked up. And in men, they present usually as hypertension. And then once somebody investigates and finds that there is a chronic pyelonephritis or scarred kidneys, and then that's how they would manifest. So now the question is that if this kidney has become scarred, say at right kidney got scarred at 5 years, 6 years, or 10 years of her life, she has another 16 years she has lived by. Now, what happens to the renal blood flow in this kidney?
Reduces, sir.
Yeah, it reduces. And usually an ultrasonologist who is not very good in detecting Doppler might report it as renal artery stenosis. So whenever, if the kidneys are reasonably good size and then you have renal blood flow and there is somebody who is good, that's why ultrasonography is, unless it is done by the same person who is interested in looking at renal blood flows for his life, ultrasonography with Doppler ultrasonography is not a good test for renal artery. So therefore, sensitivity of this is poor, and specificity is even worse, even further worse than that. So it's not a good test for finding out about, unless obviously there is somebody who spent his lifetime only doing nothing but Dopplers on the renal arteries. That person would be. And can anyone tell me the name of the person who was such a person who looked at doing this is a German radiologist who did nothing, and he published, if you look at the older literature on renal artery stenosis, and you find New England Journal articles written by this guy on diagnosis of ultrasonography, and it is, but then there are not many who, he did nothing else in his life. except looking at renal arteries, doing nothing else but Doppler ultrasonographies and making diagnosis of renal artery stenosis in people based on ultrasonography and Dopplers. But routine Dopplers, unfortunately, I don't think are done by different people at different time frames and as a part of their other activities, doing CTs and ultrasounds on one day, CT on the other day, MRI on the third day. That's how our radiologists probably, they are put on, and they may not do these day in and day out, and therefore the diagnosis. So in this patient, although I can't rule out, this would be again still in my differential diagnosis that this may be a renal artery stenosis, or it would be. So now, if you were to look at what my next investigation should be, Mohit, so what would be my next investigation? So should I do a contrast CT in geography in this patient to find out whether this patient has, or should I do something else? So how do I sort this out, this problem? So how do I sort out this problem? The choice with me is to do a CT in geography, isn't it? To make a diagnosis or confirmatory diagnosis of renal artery stenosis, or so this is the lady who's come to you. You got an ultrasound done, and ultrasound shows. So what would you do? So easier test to do is a DMSA in this patient, because my other differential diagnosis is a reflux nephropathy. So I'll do a DMSA scan and look for the scar. If there is scars, usually reflux nephropathy scars are where?
Polar scars.
Polar scars. So they help you to make that. You can have scarring even in an ischemic kidney, but usually those scars will be, where would the ischemic scars be usually? In contrast to the polar scars, they may be usually in the center of the interlobe, yeah, near the hilum and in the middle of the. So usually you will find that otherwise scars would be in other than the polar areas usually. So you may have scars which are distributed in the areas of the arterial ischemia rather than related to the polar scars in this. So, and that, why does it happen that these are polar scars? Because, yes.
So the angulation of the medullary pyramids at the poles are obtuse, unlike the acute angles seen in the elsewhere in the kidney.
How many papilla? How many papilla are there in the kidneys?
3 to 4, sir. Normal
3 to 4. 3 to 4 is too less.
8, around 8.
6.
Yeah, about 8 to 10 papilla. Yeah, usually 8 to 10 papilla in each kidney. Okay, and that's important because you might have people coming with papillary necrosis every time, and you say, okay, if there were 3, then he should have no papilla now left in the kidney, and that kidney would get totally scarred. So you have 8 to 10 papilla. So any other animal which has 8 to 10 papilla in the kidney?
Pigs.
Pig, yes, that's right. ये तो अन्वेष जी ने बताया. अन्वेष जी को तो पता था, सवाल पूछा हुआ मैंने. Pig, yes, and that's the reason. Pig is the only other animal. Usually, most animals have one papilla in their kidneys. Pig is the only other mammal which has multiple papilla in the kidneys, and that's one of the reasons the pigs become good organs for transplantation, especially kidney transplantation. And you've recently seen that this is being attempted. So pigs become good because they have similar architecture of the kidney, multipapillate kidneys, and the size of the kidney or other organs of pigs is almost equivalent to the human kidneys and all that. So pigs become the other animals which have multipapillate kidneys. Okay, so this patient, we got a DMSA scan. I actually had a scan, but I haven't uploaded it onto the presentation today. So I wouldn't be able to show you, but I have many of these where you have, and in this patient also, there were both the kidneys. In fact, the left kidney also has 2 scars which were not picked up on ultrasonography. And the right kidney is extremely small, scarred. You can't find scars because this kidney has become totally shrunken, and there is very little cortex left in this patient on the right side. But the left kidney also has polar scars, both in the upper and the lower poles in this kidney. So this patient had probably a bilateral reflux. The right kidney got damaged much more because of probably a greater reflux at that point of time in this. And so this patient has pyelonephritis, chronic pyelonephritis or interstitial nephritis related to a probable reflux. Now, the question is, should we look for reflux at this point of time in this patient? Is it of importance or is it not that important?
So not important.
Not important at this point of time. Why?
So because in pregnancy, there is because of hemodynamic changes, there is already the physiological hydronephrosis.
No, I'm saying that if this was not a pregnant patient, this is a male.
It is important, sir. It is important because we could prevent further damage.
You could prevent further damage.
To the contralateral
So
kidney.
which kind of reflux? So what would you do to find out whether you need to intervene or not in this
So
patient?
we should check for posterior urethral valve also in case of male.
Sir, we should look if it is a primary or a secondary reflex.
Yeah, that's important. So you should look at, is it a primary or a secondary? So what I would do is, this lady, I would now go back to the history because we didn't ask specifically if there were any urinary specific related to her voiding itself. Was there difficult voiding? Does she have to do a double voiding or something of that sort to pass urine? Maybe she doesn't pass all the urine in one step. So I would look for an ultrasound now specifically to see if there is a residual urine remaining in the urine or not. And then if there isn't any residual urine, there are no, the bladder on ultrasonography doesn't, I don't want to do an invasive test unnecessarily in a person if there are no symptoms related to this. And on ultrasonography, I specifically ask the radiologist to look for what is the bladder like, full bladder like after she has drank it. And I would look for bladder after voiding. Does she retain some urine and all that? That makes me suspect that if there is a bladder which is 50% emptied after full emptying and there is residual urine, then I would need to assess this bladder further to find out whether there is. Then only I need to investigate this patient for reflux. Otherwise, there is no history of urinary tract infection. She has no symptomatic urinary tract infection, and there isn't any other reason. So there is no advantage of intervening in people who do not have any primary defect at this point in the bladder. So if the bladder is good, usually reflux in these adults doesn't mean much unless there is recurrent urinary tract infections in these patients. So this patient hasn't had any urinary tract infection till this period of time, and the bladder is normal. There is no residual urine in the bladder, so I don't need to investigate this patient at all at this point of time.
Sir, I have a query, sir.
Yes, please.
Sir, we know that one kidney is 6 centimeters in size.
Yeah.
And the other kidney is still spared 9 centimeters in size, and kidney is around 1.8.
Yeah.
If there is a reflux present, first of all, we will see a significant hydronephrosis, because for a reflux, for the CKD and reflux nephropathy, it cannot be a low grade reflux and it should be a high grade reflux, which usually manifests in the form of hydronephrosis on ultrasound, sir.
Yeah, may or may not. As I said, that many times what happens is these reflexes initially 3 and 4, although many of them may not recover, but usually majority, 60 to 70% of reflux will disappear in majority of children. Majority of children. They would have caused damage and there is no residual reflux in them. You may have grade 1 reflux, you wouldn't do anything. Even if you have grade 4 reflux in an adult, unless the bladder pressures are high, and that would be documented to me where if there is someone who is passing urine out without, I don't see great dilatation of the ureteric system, which would tell me that the bladder pressures are high. If that is not on ultrasound, ultrasound shows me a relatively normal looking kidney, no hydronephrosis, I would not expect the bladder pressures to be very high. Okay. So in that sense, there is no residual, and there isn't any reason for me to look at for that kind of thing. Okay. Now these scars will progress on their own. There is chronic kidney disease on their own. That's the reason why children who were operated, see, this surgery used to be done intrauterine also. I'm sure you would have read the studies where people thought that if we reduce the reflux intrauterine, because many of these children are born with scarred kidney. Ask upmark kidney was nothing else but a reflux which happened intrauterine. And these children were born with a scarred kidney on one side or the other side. And that was labeled initially as ask upmark kidney. It was considered to be a congenital abnormality, but later on was documented to be nothing else but a part of the intrauterine reflux. And many urologists thought that they could go intrauterine and try to correct this intrauterine. And a lot of surgeries were being done intrauterine at some point of time. But all of it is stopped. You don't hear of this being done these days. And in fact, many children got operated for reimplantation of ureters unnecessarily. The outcome of these kidneys was same whether you operated or you didn't operate. An unnecessary surgery in children, not one surgery, multiple surgeries. And you have even these days unnecessarily stents, deflux, all kinds of anti-reflux procedures being done in a lot of adults who don't need it. I haven't done this in all my 40 years of my life, of my practice. I haven't seen anybody, at least I haven't sent anybody. I have seen many patients who had these surgeries, but in most of these surgeries were futile. They were not needed in adults. They are needed sometimes in children. Occasional children, you will need it. Stage 5 reflux in a 2-year-old kid who has had recurrent urinary tract infection despite antibiotic prophylaxis. Yes, might help to prevent that acute pyelonephritis in that child. But 20 years adult with stage 4 reflux, bladder not showing any abnormality, I wouldn't do anything to that. And there is no urinary tract infection. Why would I do anything to that person? Just because the nephrologist or urologist feels that this is not looking good. It's like putting stents in coronary arteries. We don't require stents. These are the same kind of surgeries being done in nephrologists. Don't think that nephrologists and urologists are any better than cardiologists. We blame cardiologists that they put stents in places where there's no need to put stents, and we consider that we are holy cows ourselves, and we feel that we are above every board, above everything. So there are a lot of surgeries in these kind of patients being done in people who don't require. So in adults, by and large, unless there is high pressure bladder or unless there is obstruction, which you said very rightly, you want to see whether this is a primary or a secondary. So if there is an abnormality in the bladder and there is a high pressure, then obviously you need to release the pressure in the bladder. Bladder is a low capacity, low pressure, high capacity. It's a container which is got a low pressure and high capacity. So that's what we should try to keep the bladder as. And if there is abnormality, then we need to do something about that. If this becomes high pressure, yes, I need to do something about that, but not without that. Okay. So that's as far as the this patient is concerned. So we did a DMSA scan and he showed bilateral scarred kidney. So the diagnosis, I wouldn't do even a contrast study now to document that this is renal artery. I would guess that this kidney was so small, scarred, very little on DMSA, also very little kidney tissue left in this on the right side. And this, the artery story is probably a secondary renal narrowing, which has happened in this small kidney, and which the radiologist is saying that and many of these kidneys, probably, if you send it to a cardiologist, now the 6 centimeter kidney will be put a stent. I have had patients doing that also. That many people, because it went from radiologist straight to a cardiologist. Cardiologist thought this was a renal artery stenosis. So they put stents in these kidneys. Nothing happened. The blood pressure continued to remain high, and these patients, so there was some damage which occurred to the other kidney as well, maybe contrast or whatever. So those kind of things have happened. Clinically, I have seen that happening. So you should always look at these, sort of analyze them, and then see what happens. Okay. So that's it as far as this is concerned. Now let's discuss something about the management of this patient. So what are the goals for this patient for management purposes? We said that we are not going to investigate as far as what is the persistent sort of reflux in this patient at the moment. I'm not, the ultrasound didn't reveal anything. So what should be the goal? Our goal is now, this patient has chronic interstitial nephritis. I can't do much to reverse the damage which has already occurred. So what would we do next? So we need to slow down the progression, isn't it? And prevent complications of chronic kidney disease. So most important thing to do is to prevent progression. Yes. Yes, go ahead.
Control the blood pressure.
Yes, control blood pressure. So what would be the target blood pressure?
So less than equal to 130 by 80 mm of Hg.
Yeah, less than 130. Although the goals of blood pressure control are changing, the normal blood pressure now being 120/80. So in a young person, I would want the blood pressure to be less than 130/80, preferably as much as nearing 120 and 80. I wouldn't. That if this was a 70-year-old person, yes, 130/80 may be okay. But for a young person who has another 50 years to go by, and you would look to slow down progression of kidney disease, most important factor. And what drug would you use? Yes, Shashank. Who is it? Yeah, Shashank. No, Vivek. Angiotensin receptor blockers.
So ACE inhibitor or ARB, sir?
ACE or ARB. So you will use ACE or ARBs. And so what will be your target for up titrating the dosages of ACE and ARBs? So one is the blood pressure, which you said would be, say, target below 130/80, go to 120/80 or even lower, as much as well tolerated, as she doesn't have any adverse effects of hypotension or giddiness and all that. And anything else you would target?
Sir, to optimize the dose of ACE inhibitor ARB, we see the increase in serum creatinine.
Yeah, that's okay. That you will see increase in serum creatinine, but that will happen only.
Decrease in proteinuria.
Yeah, decrease in albuminuria, which is what most nephrologists don't do. And I'm sorry to say, that's why I'm on this to be highlighted. So optimize ACE inhibitors for two things: control of blood pressure. That's one target. Second target for nephrology should be albuminuria. And unfortunately, I must say that in my practice, people coming for second, third, fourth opinions, you find nephrologists lacking in targeting. There are patients whose albumin has not been quantified. Urine routine analysis showing no albumin and no quantification of urine, because they believe that there is no albumin in urine, because urine routine doesn't show albumin. Urine routine many times in the labs is not done. These reports are just fake reports. So please, this is done at the fag end of the day, if at all they are done. The most inconsequential of the tests is the urine analysis. And I do not trust urine analysis unless it is done by my own self. Otherwise, I would always quantify albumin, and albumin is an important for nephrologists. I can't believe that nephrologists don't quantify. It is an independent risk factor for mortality, independent risk factor for progression of kidney disease, independent risk factor for ESRD, independent risk factor for cardiovascular mortality. So I'm surprised that Dr. What is that guy's name? I forget, the Swedish guy who used to ask the cardiologist, you must make your patients pee and look for albumin in the urine. But I find that nephrologists, at least the ones I see the prescriptions of, haven't quantified for years. They haven't quantified albuminuria in patients. And albuminuria should be quantified not only in glomerular disease, albuminuria needs to be quantified in every chronic kidney disease patients. Because you have now therapeutic drugs which can reduce that. And reduction of albuminuria in interstitial disease, in glomerular disease, in any disease, in polycystic kidney disease, it's a marker for progression, it's a marker for mortality. So it should be targeted. In every disease you need to target. So try to increase it to tolerable levels of ACE or ARBs. Keep on going up and up till you reach the optimal doses. We suboptimally use ACE and ARBs in our practice. And that's what I want to convey to you. Use them optimally. And when you are talking of optimal use, increase the dosages till, unless patient develops adverse effects or the blood pressure keeps dropping too much, which is beyond the comfort zone of the patient. Otherwise, targeted to achieve an albuminuria of 50% reduction or more, and from macroalbuminuria to microalbuminuria and microalbuminuria to normoalbuminuria. So you should look for acidosis. The other thing which I commonly find is that people give soda bicarbonate because it's been documented in randomized trials to slow down the rate of deterioration, but without looking for bicarbonate in it. They never measure bicarbonate. They keep on giving it. You have uncontrolled blood pressure in people. People whose blood pressure is 4 drugs not controlled. They continuing 3 grams of soda bicarbonate. This bicarbonate never measured. You do bicarbonate, it is 28, 32. This patient is alkalotic now, but never measured. So whenever you use bicarbonate, find out if the patient is acidotic. Yes. If the bicarbonate is 20 and less, yes. 22 and less, yes, use bicarbonate. But if it is 26, 28, don't use bicarbonate. Why do you want to give bicarbonate? Because that's not needed. And the other drugs are Sglt2 inhibitors. And these days, anybody with any degree of albuminuria and chronic kidney disease, irrespective of whatever disease, you already know that instead of using drugs, futile drugs, keto analogs, coenzyme Q, acetylcysteine, selizurine, and now even prebiotics, probiotics. I don't know what evidence, I don't know where do you read these evidences from, but these are the drugs which I find, and many people feel that these are the kidney drugs. They stop antihypertensives, AS and ARBs, because people tell them these are blood pressure medicines. And they don't realize that blood pressure is perhaps the most important thing that is important for a patient with kidney disease. They feel these are kidney drugs and these are not kidney drugs. So I feel that you should look at evidence-based practice of management of these patients, cut down on the load of tablets that the patient takes. Because these patients are taking keto analog 6 tablets to 12 tablets, selizurine 4 tablets. I don't know what selizurine is, but acetylcysteine, I find it usually, and uric acid. So, Vivek, would you give uric acid lowering agents to a person? This patient's uric acid is 7.4. So what is your take on using a uric acid lowering drug like allopurinol or febuxostat?
Sir, I wouldn't give a hypouricemic therapy because trials have shown that it does not halt the progression of CKD, sir.
And uric acid is not a marker for reducing mortality in these patients. So two things: it's not important for development of end-stage kidney disease. It's not important for progression of kidney disease. It's not a marker for end-stage kidney disease in any condition. So unless patient has symptomatic uric acid disease, asymptomatic hyperuricemia, unless uric acids are beyond 10 in patients of chronic kidney disease or 11, I would not use uric acid drugs. And you need to tell this to your patients because they come out with these reports that uric acid is gone up, is 7.4. Anything that they see in bold letters, they come and the first complaint they have when you ask them what is the complaint, they tell you the uric acid is gone up, creatinine has gone from 1.04 to 1.08. So these are the kind of things where people come with. So you will have to educate your patients about it. And I think it's important not to use drugs like these. So pain relief. She has a swollen knee because she's come with a bruised knee. She had a fall. So what kind of painkillers? She says that she's been using paracetamol and tramadol and it has not given her relief. So she says that she took 2 tablets of Brufen. So what is your take on use of non-steroidals?
But if we are starting ARBs, then giving NSAIDs will be disastrous. Like it will reduce the GFR.
Mm-hmm. Yeah, it would. But the non-use or advice about non-use of non-steroidal anti-inflammatory drugs in chronic kidney disease is slightly overstated. I'm not saying that you should advocate the use of non-steroidals in patients, but once in a while, if the pain is not relieved by a judicious use of non-steroidals in chronic kidney disease is not something that you should be. Don't let your patients suffer for pain. Actually, Indians by and large are very impervious to the sensibilities and sensitivities of pain of our patients. We feel कि थोड़ी सी दर्द तो जरूरी है, अगर बीमार हो तो दर्द नहीं हुआ तो फिर क्या होगा? तुम लगते हो कि नॉर्मल तरीके से रहोगे, ऐसा नहीं होगा, थोड़ी सी दर्द तो सहनी चाहिए. So we feel that some amount of pain associated with procedures or associated with certain illnesses are okay, and they can either suffer through the pain or use ineffective pain medicine. So the point I am wanting to bring out is that an occasional use of a non-steroidal drug, yes, regular use of non-steroidal drugs is bad for kidneys, is on a regular basis, but once in a while, don't deny pain relief to a person. Either you use other pain relief measures, but provide effective pain relief. Pain relief remains highly ineffective in patients of chronic kidney disease, and it's our burden of duty to. And if you look at the evidences for non-steroidal anti-inflammatory drugs, yes, they can cause aggravation of hemodynamic disease in people with chronic kidney disease, but there is a huge amount of literature now appearing that it's not always associated with abnormalities. And so don't kill somebody because he prescribed or the patient by himself took a painkiller which provided him greater relief for short period of time. So help them to use it judiciously if at all they have to use it. Before I finish, I think there are 5 minutes more. This patient has 3 questions. She says, can she have another child? And if she has to have another pregnancy, when do you think you would advise her to become pregnant? And the last question she has is that, will her kidney disease progress that she will require dialysis or transplantation sometimes in her life? So anyone can we answer the first question? Would you advise her for another pregnancy? And if so, when? Would you want her to wait for 3-4 years and then go for pregnancy, or would you want her that she should try pregnancy early, maybe another 6 months? So what's your take on this?
Pregnancy is not advisable, sir. Second pregnancy, but if she insists, then it should be early.
What do you mean if she insists? So she says that she wants a pregnancy, and you have had a discussion. You tell her that usually such discussion should be done not only with the patient, but with the spouse as well. So you should usually call the spouse and call both of them, and then tell them the pros and cons of what happens. So in a patient, this is a patient who's got a chronic interstitial disease, chronic pyelonephritis, creatinine of 1.8, 1.9. So she says she wants to, both of them decide that they want to have pregnancy. So what are the chances that she can go through this pregnancy successfully? So what are the markers which determine bad outcomes in pregnancy?
So
So
the
there are-
persistence of hypertension and
Yes,
proteinuria.
yes, uncontrolled hypertension. But if you are able to control hypertension well in this patient, anyway, you given her ACE and ARBs, and you would want to watch her for maybe 6 months or so. So obviously, while she is on ACE and ARBs, she can't become pregnant. So you will tell her to use contraception when they are using ACE and ARBs. So it's extremely important to discuss contraception in patients who young adults to discuss, especially say women becoming pregnant. You should discuss contraception in them. So whenever you start ACE and ARBs in a young lady, then do discuss contraception. Don't hesitate to do that. That's very, very important, because accidental pregnancies are as bad as going through a full-fledged pregnancy. Abortions are bad for kidneys, even worse than undergoing a full-fledged safe pregnancy. They can get infected and all these. So abortion. So it's therefore essential that we talk about contraception in these patients. And so every nephrologist must be aware of, and then maybe discuss this with the gynecologist, what could be the safe and effective contraceptive methods which needed to be given, because some of the drugs may not be as effective, and others you need to discuss all the pros and cons of various contraceptives in a particular patient. So I think it's important to discuss contraception. Second, sorry, as Mohit said, that I would normally see nephrologists usually take a position of sort of, and many gynecologists, obstetricians as well, that anybody with kidney function, you will tell them the bad effects of it. They want to become pregnant, and I think it's our bound duty that we should help them if they want to become pregnant, to sail them safely through this pregnancy, knowing that this can be a difficult task, and she might go over a road which is not smooth. So you should tell them that there are going to be chances, but if at all they want pregnancy, then it's good to have pregnancies early rather than late, because kidney disease is progressive. The kidney function is going to go worse. So I would rather have a lady go through pregnancy when proteinuria is not very heavy. So I obviously will have to control the blood pressure with drugs which are conducive to continued pregnancy, and see that the kidney disease doesn't progress during that time. And the proteinuria, which I had very well controlled with ACE and ARBs, but now I change into calcium channel blockers or to alpha methyl dopa, which is usually not available these days. So you usually have either nifedipine to use in these, or you will use, what are the other drugs?
Labetalol.
Yeah, you would use an alpha and labetalol as a drug for that. So labetalol, nifedipine, this is usually what you would use in these patients. But you may have aggravation of proteinuria in this kind of a situation, and then there may be even deterioration in kidney function. So you should look for 3 to 6 months before you advise them to become pregnant, to change them to these drugs after you maybe control them for some period of time with these other drugs, seen that the kidney function is stable. And if the kidney function is stable, you should help them to become pregnant and handhold them with a gynecologist or an obstetrician who also listens to you, because many times the nephrologist may be keen to handhold the lady, but the obstetrician is not there to handhold the lady. So you need to have people who are well versed with high risk pregnancy, because this is going to be a high risk pregnancy. There are going to be prematurity, there is accelerated hypertension, deterioration in kidney function, low birth weights, and all these complications, preeclampsia superimposed on chronic kidney disease. So you should be well versed with handholding, but it's better to do it early rather than late, because with deteriorating kidney function and deteriorating proteinuria, it's not going to be as good. So we should do it early. Now, how about, what do you think are the chances of this patient progressing to advanced kidney disease? What and when would you reverse? She's got a GFR of about 37. Yes, eGFR of 37. And so this is already a stage 3B kidney disease. So, but she is being managed by a very efficient doctor like you, who is very hopeful that he should be able to control the blood pressure well, and creatinine, which is about 1.9, maybe. How many years would you think? Yeah, Vivek.
Sir, if we control the blood pressure, but still, sir, pregnancy can
No,
cause
I'm saying now pregnancy is over. We decided that we will allow her, if at all, during that. No, I'm talking of now. The other question she had was that the husband also came. Will she require? She's 26 years of age. Will she require dialysis or transplantation?
Yes, sir.
And if and when. So what will
Sir,
you tell her? What would you, if I was the spouse of this patient, and if you were to tell me, I ask you, डॉक्टर साहब ये बताइए, ये कब इसको ट्रांसप्लांट और डायलिसिस की तैयारी कब करनी चाहिए, तो क्या आपका क्या जवाब होगा? So what will you tell me?
Sir, CKD being an irreversible progressive disease, ये transplant और dialysis की नौबत तो sir inevitably आएगी, but right now it is not required. You can continue on the conservative management. Once the GFR falls below 20 ml per minute, then we could start planning for a transplant, and ultimately we could plan a preemptive renal transplant. But
so
that is not to be.
So what will you tell me? भाई भूल जाओ, आप आराम से रहो, बीवी का ध्यान रखो, मौज मजे करो, यही?
Yes sir, yes sir, yes sir.
मौज मजे करो. Yeah, yes, I think many kidney diseases, you have a natural history of progression of kidney disease known in patients. Like diabetic nephropathy progresses much more rapidly, 5 ml, 3 to 5 ml per minute per year, kind of a drop in GFRs. And you know that in 5 years time, this GFR would be less than 50. So it will go down in another 3-4 years. So, but glomerulonephritis, chronic glomerulonephritis, polycystic kidney disease, same interstitial disease. So it is true that albuminuria is a marker for progression, but then if you are able to control blood pressure and albuminuria well. So what I will tell this patient is that, okay, let me go through, if this is day 1, day 3, or day, say 2 months after you've seen this patient, I'll tell them, maybe give me another 6 months to a year to see how is she progressing. I'll see the rate of deterioration of kidney function in this 1 year period. I'll see her maybe every 2 months or so. Look at the blood pressure control, give her drugs which are effective in controlling progression of kidney disease. And fortunately, now there are more and more drugs coming, Sglt2 Inhibitors, ARBs. These are helpful. And if I am able to reduce proteinuria, both the progression of kidney disease might be slowed down, and it might take many years. Sometimes maybe 5, 10, 15 years also, that the patient may be able to carry on like this. slow progression, deterioration of 1 ml or so, and it might take another 20 years for somebody to reach to a GFR of 10 ml or so, and before that requires kidney transplant. So you might be, so you could buy some time and tell them that don't worry, reassure them. Our aim should be not to unnecessarily also create panic in a young couple. Nutrition is important, and I think we didn't talk about nutrition, and I thought that that would be a separate class. I'll take some time on nutrition itself, but don't restrict proteins and necessarily food and all that. Proteins are important. Indians are by and large very low protein intake. So vegetarian proteins, fruits, and other things are also restricted to a very large extent. And I hope you read the study in Jason that potassium, in fact, the oral potassium intake has no correlation to serum potassium, and that has no correlation to mortality. You should read this because this is relevant to people with nephrology, because we restrict people from taking potassium and feel that potassium is so toxic, whereas potassium is healthy. Potassium is good for control of blood pressure, good for the heart, and good for everything. Good for control of blood pressure, which we want to be good. And we believe that it is toxic to kidneys, and therefore we do not allow them even a morsel of good food to eat. And they live searching and dying for that food for 10, 20 years. And then the transplant comes, and then you stop further any foods and all that. So I think it's important to be objective in your assessment of what the needs of the people are, and look at that. There is greater and greater evidence coming that potassium is being unduly restricted, not only in early stages of chronic kidney disease and moderate stages of chronic kidney disease, and even in advanced stages of chronic kidney disease. Potassium is definitely excreted poorly by the kidneys, but still body is able to compensate through various mechanisms about this. So be logical about it, be sort of objective about your restrictions in patients. Hyperkalemia, even in the best of the studies, not more than 15% of patients where this is monitored on, and potassium of 5.5 is more than 5 is considered to be hyperkalemia. 5.5 is considered to be more than severe hyperkalemia. Where it is severe hyperkalemia, 1 to 5%. In all chronic kidney disease, hyperkalemia, 15%. 85% of patients will not have this kind of thing. And this is what you also see in the clinical practice also. But because of the fear that one patient may have died of hyperkalemia, you will not allow good food to be eaten by 85% of your patients. So because you've seen that one patient, I agree that you can prevent fatalities in an occasional patient by doing this, but the potassium, serum potassium, has been shown to have no correlation to oral potassium intake, no correlation. So I would suggest that you should read this Jason study, which has recently been published, and it was presented at the ASN as well, and has had no impact on the survival of these patients. So in fact, higher potassium in the diet has been considered to be a good impact on survival of chronic dialysis patients. Lot of studies which you need to look at. So I think I will stop here. And if there are questions, then I'll take 1 or 2 questions and then we will stop.
Sir, in this patient, ARBs would be preferable than ACE inhibitors, or would be equally preferable?
Actually, I don't think there is that kind of comparison effectiveness of ACE and ARBs. ACE if are cheaper than ARBs. Some of the ACE inhibitors are cheaper than ARBs. So if there is a patient where I have to use cheaper drugs, cost becomes an important issue, and I think cost should become an important issue in each and every patient, depending on which patient you are seeking. So I might start ACE inhibitors in a patient But at the moment, if you ask my personal choice, I would use ARBs. Unfortunately, in our country, these drugs are reasonably cost effective now. So I would use a longer acting ARB, and I usually use either telmisartan or olmesartan, telmisartan being my favorite beat. So I use usually because it has least side effects. ACE inhibitors, obviously cough does occur in about 30% of patients, 25 to 30% of patients. So otherwise, usually either an ACE inhibitor or a ARB, I don't think I would fight with someone if an ACE inhibitor is started. Anything that the patient can tolerate well, good enough. But optimize ACE use, that's important. You may start with 2.5, but go up to 5, go up to 10, and maybe if you need some more also in some of these patients, target blood pressure and albuminuria. Yes. What else? Anyone else? Anything? Any other question? If none, then I think thank you very much.
Sir,
And
one last question, sir.
yes, please.
Sir, when to exactly start SGLT2 inhibitors? Like,
Yeah,
at the
what I
point.
do, see, let me tell you, what I do is obviously, the question is that now that they become available, should you start SGLT2 inhibitors first, or should you start ACE or ARBs first? I usually would start ACE or an ARB, unless of course somebody has a blood pressure of say 100/60. Now you are scared of starting an ACE or an ARB because your blood pressure might fall further in this patient. So if albumin, now you want to slow down the progression of a patient whose blood pressures are already low, and obviously then I would start an SGLT2 inhibitor in that patient, because that has a lesser impact on the blood pressure. It can also reduce blood pressure to some extent because of its natriuretic effects, but it is, the impact on blood pressure is 2 to 3 millimeters of mercury, maybe 4 millimeters of mercury, whereas the impact of ACE and ARBs obviously is much higher on the blood pressure, and they might produce hypotension. And if at all, I still use, even with normal blood pressure, I use ACE and ARBs, but I usually start with a small dose, say 20 to 40 milligrams of telmisartan, and give it at night. If one drug is to be used, I give it at night. One is that the peak impact of this drug goes away by the time the patient gets up in the morning. So it's usually the dwindling doses at telmisartan X 24 hours, usually about 24 hours. So the peak effect of telmisartan is gone by the time the patient gets up in the morning. And then ACE and ARBs are usually well effective. If only one drug is to be given as an antihypertensive, also I usually give it at night. It also prevents the morning surge of blood pressure, which occurs usually in the morning. Cardiac events are worse in the morning. Stroke is worse in the highest incidences in the morning, and that happens because of the increase in the morning surge of blood pressure. So drugs, if only one drug is given for blood pressure control, then I would give it at night, because a long-acting drug given at night, and ARB would be the best. So I would use it. But after 3 to 4 weeks to 6 weeks of using ARB, now if I've reached full dosages of angiotensin receptor blockade, then I would add an SGLT2 inhibitor. I usually don't combine them together because they may have much more hemodynamic effect. All of them will reduce intraglomerular blood pressure. So you may have sudden decline in GFR, and the creatinine might go up all of a sudden, and your creatinine going up is not good for the patient, because they come next time they come, they say, "Arey, doctor sahab, ye achhi dawai aap badi tareef kar rahe the creatinine to," and do educate them. Then for some period of time, initial 2 to 3 months, the creatinine does rise in these patients, but look for preventing volume depletion in these patients, and you must educate them about volume depletion and sick day rules, that they may stop these drugs when patients have diarrhea or fever, or they get admitted for operations and all those. So they must stop these drugs for 2-3 days and then restart them once they have recovered from these conditions. So it's important to talk about 6-day rules, both for SGLT2 inhibitors as well as for ACE and ARBs.
Sir,
Okay.
one question from my side, sir.
Yeah.
Sir, one question from my side.
Yeah.
Sir, I want to know, sir, up to what level of creatinine should we give ACE or ARBs, sir?
I'm
Suppose
surprised.
the patient is having creatinine of 3.
I'm surprised that you are asking this question. As a nephrologist, you should be knowing that there is no level of creatinine where you cannot use ACE or ARBs. Every level of kidney function you can use. I have large number of patients on dialysis who are on ACE and ARBs. I have large number of patients on CKD5, CKD4, CKD3, where GFRs are less than 45 or so. Creatinine may be 3 or 4 also. I continue to use ACE and ARBs in these patients whenever they are indicated. So there is no level of kidney function which is it. I would watch for hyperkalemia might, as I was talking about this. Even in advanced kidney failure, hyperkalemia occurs in less than 5% of patients, severe hyperkalemia. And hyperkalemia of potassium more than 5. My level at which I get bothered is about a potassium of more than 6 or above. So I would watch for hyperkalemia in an occasional patient, but I wouldn't worry too much about it. So I would use, even if there is no renal benefit, there is a mortality benefit with ACE and ARBs, and that has been shown in stage 4 and 5 as well. And you would want your patients to live longer. And ACE and ARBs provide you that. They prevent cardiovascular mortality and overall mortality. And this has been well documented in a lot of studies now, where people have used ACE and ARBs in late stages of kidney disease. And they may not have impact on kidney disease, but they will have impact on mortality. Your patients survive longer with ACE and ARBs because they produce less cardiovascular and overall mortality. So this is a question usually asked by physicians and cardiologists. And I think as a nephrologist, it's your duty to tell them that don't be scared of ACE and ARBs. And if nephrologists themselves get scared of ACE and ARBs, then I would feel pity for the rest of the physicians as well as cardiologists. Okay. Okay. Anything else? Okay. Thank you very much. Good night.
Thank you, sir.
Bye-bye.
Thank you so much, sir. Thank you for the
sir.
enlightening
Thank you,
session, sir.
Okay.
Thank you very much. Thank you very much.